Welcome to Among the Lilies. This is a show for ladies who are tired of pretending and are ready to be real. I'm your host, Cameron Frad, and in today's episode, I'm actually interviewing my real life doctor. Dr. Strassberg has been so lovely in agreeing to come on. So welcome to the show, Dr. Strassberg.
Thank you. Thanks for having me, Cameron. Nice to be here.
Yeah, I really, really appreciate it. I find you such a wealth of knowledge, and I'm just really excited to share you with all my ladies that listen, and just so many women all over the world, actually, that don't necessarily have access to really good doctors, especially that kind of focus more on chronic pelvic pain. So why don't you go ahead and introduce yourself? Tell us all about you.
Yeah, sure. So my name is Jessica Strasberg, and I've been a Cleveland native for my whole life, and I work at the Cleveland Clinic. And I actually trained in family medicine, did my residency at University Hospitals in Cleveland, did a one-year women's health fellowship, and so glad I did. When I joined the Cleveland Clinic in 2002, I was able to have a joint practice in gynecology and family medicine. So I had patients of all ages. I had babies to elderly patients, and really enjoyed my practice. And then in 2016, there was an opportunity for me to see patients in chronic pelvic pain, treating them medically. And this was a field that I was really not very knowledgeable of, as I will admit now looking back. Developed my training through an OBGYN who specialized in chronic pelvic pain and endometriosis. And so I've been doing that since then, and I had to give up, unfortunately, my family medicine practice. And so, but it's been a good change, and have learned so much, and love the fact that I have a background in general medicine, which has helped in chronic pelvic pain immensely in terms of medical therapies and what I look for, and have really enjoyed the field. And it's a difficult field, so talk about it more.
No. I think it also, the fact that you have seen babies to elderly, like you've seen the full spectrum of women. And I think seeing like, okay, this is how our bodies start off and this is where we end up. And obviously, depending on whether you kind of follow the normal or you have issues in the middle, like it gives you a wider reference, which I think is really interesting to have that as the background prior to diving into to the chronic pain. So what was there a need base for the chronic pain, or was it something that you were just passionate about? What led you there?
Yeah, I really didn't know about the field, and it was a friend, colleague who asked me to join her, who was a surgeon who really developed the program at the Cleveland Clinic definitely out of need. And what she was seeing as a surgeon was these patients that she was operating on for pelvic pain being diagnosed, most of the patients being diagnosed with endometriosis or other conditions, they would improve yet come back with pain. And she saw this pattern and kind of almost like a lack of knowledge. And there was an over focus on doing surgery on these patients. So they would get surgery after surgery, and young patients in their 20s and 30s getting hysterectomies, ovaries removed, really affecting fertility, and really not seeing as much of an improvement as she would have liked. So the field has grown tremendously. And I joined the International Pelvic Pain Society, learned so much. I think there is still a tremendous lack of knowledge. So I still think there's a huge need. Have really become passionate about patients with pelvic pain, teaching other physicians how to diagnose, especially pediatricians, because I think this condition can start as young as someone in their teens, actually. So
yeah. So if someone had asked me prior to me seeing you, if someone asked me, do you have chronic pelvic pain, or even do you have pelvic pain, I would have been like, no, I just have endometriosis and all this stuff. But I think we're not as aware of our bodies. I remember I was so when I first had my very first pap smear, like I remember it because it was like a nightmare experience. It was my childhood doctor. I was driving, so I think I was 16 years old. I was not sexually active. I went in for what I thought was just a checkup, and he explained to me that I was having a pap smear. I don't think I even knew what that was, but I knew, wait, I don't want that. And I was like, no, I think I need to talk to my mom about that. And I don't even think I really knew what it was, but I knew it had something to do with female stuff. And I was like, I don't feel comfortable. And he's like, no, I already talked to your mom. She approved it. A nurse came in, reassured me, honey, it's going to be totally fine. Just get undressed, put a gown on. And I remember just being petrified in the office. And I was really scared and kind of afraid. And they were like, okay, you just need to relax. It'll be fine. They went to do the exam and they had a very hard time. What do you call the tool that they use?
Speculum. Like a speculum.
Yeah. So
it was either metal or plastic.
It was metal.
Yeah.
It was metal. I remember it. It didn't fit. And so they said, we just need to call down to the children's ward. We need to get a pediatrics one. And I remember just being like, no, I just don't want to do it. I don't want to do it. I'm fine. Like, I just want to go home. And they're like, no. Like, this is the hardest part. Like, it'll just be really quick. And sitting in that office, like, I don't think I was there that long, but it felt like I was there for a very long time. And then they finally did it, and it was excruciating painful. And I went home and I was just angry. I was mad at my mom. I was mad at the doctor. And like, no one explained what it was. No one explained what was going on. Like, I had really bad acne, so I was on the pill because of my acne, but I wasn't sexually active. But it was like, we're not even going to talk about your pelvic region or your female anatomy. I think that we don't. I have a very open conversation with my girls, and I try to from the time they've been very young. But I just think that was not the way to go about it. But
no. That's so interesting because when I trained, so I started training as a med student, I remember that, we really weren't, the guidelines on pap smears was much different. It was, 3 years after you're sexually active, that was sort of the guideline. So if you were 15, you would get it at 18. And even then, if you were putting someone on the pill, it was recommended to do a pelvic exam. And this was as a student and a resident. Things changed. And I think what happened was what happened to you. We started realizing, well, you don't have to do a pap smear on girls that are not sexually active because the risk of cervical cancer is 0 if you're not exposed to HPV. So one thing is, I think we traumatize a lot of girls, and I think that's come out in the guidelines is that really it's individual. And so while I say right now the guidelines are age 21, to start doing pap smears. That's much older than what you had done. And even then, it is not recommended in any guideline they need a pap or pelvic to start someone on the pill for acne or even being sexually active. So if you have an 18-year-old, I normally don't do a pelvic unless they have a problem. If you have something specific you're looking for, I definitely would still try to avoid the speculum exam, but I don't force a speculum exam or even a pelvic exam unless there's a specific reason I'm doing it. And I explained it thoroughly to a patient why I'm doing it because they're so scared when they come in. So I think we didn't unnecessarily traumatize girls like you. And it continues, and you can develop pelvic pain from that, solely from that specific instance. And so creating more problems. Now we kind of have like very specific guidelines. Why are we doing this? I talk to my patients. Even I have patients who are 25, never been sexually active. The other thing I'm going to mention is that intercourse is not necessary to get HPV. So that is something else I kind of ask my patients about is, have they been with a person where they've potentially been exposed? And it could be skin to skin exposure. So you don't need to have penetration or intercourse. So that's something I think important to discern. But if they were like, I've never touched another person, then I might wait, especially if they're really scared. The other thing is, they should have had a pediatric speculum. If they're going to do one, like have it available. You have a 16-year-old who's like virgin, I think then you have to wait. It's creating more anxiety, so they should have been more prepared. And
I think they didn't believe me. Well, what I got from it was they didn't believe me. They're like, well, no, obviously you are. And I honestly had a boyfriend at that point, and I think we kissed like 3 times. Like that was it. Like that was the extent of my, So after that point, I found I was like, I'm not going back to that doctor. I found an OB and I told them, I'm like, I am not sexually active. I do not want you to do a pap smear. I was not in the danger area for HPV or anything else. And they respected that. and
That's
they
good.
waited, which was good, and I appreciated that. And I also just realized I have to be my own advocate. Like I can't just go off what the doctor says, and so I feel
Right.
like that. But I think you're right. I feel like I was part of a different generation where it was like, if
100%.
you're going on the pill, we're going to do this, which I think now is
Yeah,
so
I
much
mean,
better.
yeah, I agree. And I look back and I believe that happened to me too. I was put on the pill.
Yeah.
So, and I was definitely not 21. So, and yeah, you just kind of go along with it because it's a doctor, they're an authority and they know what's going on. And so I think that hopefully girls and moms advocate for their daughters. And I also, this has a lot to do with pain and painful periods and what's normal. We can talk about that. But the other thing I'm going to mention is that what we do now is for anyone who we think might have an STD, you can check for that off of urine testing. So
Oh my goodness, so much easier. Pee in
yeah,
a cup.
so much
I'm
easier.
all
You
about
can
that.
check for gonorrhea and chlamydia off of urine. I often do that for my patients less than 21 who may have a partner. And still talk to them about safe sex and things. But yeah, so it's much easier, less traumatizing. But at 21, if someone is sexually active, we're going to talk about that. And they're probably, at that point, they're old enough, they're open to doing that. And again, we can have a smaller pediatric size speculum. And I think having like a gentle approach, not rushing through it, is always helpful for these young patients when it's the first time. If you traumatize someone, they're going to not go to the doctor. They're going
Right.
to hate the doc. You know what I mean? They're going to avoid the doctor, which is really could worsen their health. And then they may avoid going for any other reason. Like my doctor's not going to listen to me like you did. Like they didn't listen to me.
Yeah.
So why should I go
Yeah.
back? And I see that a lot too. So.
Yeah, and I think so. The majority of my audience, not everyone, but the vast majority of my audience are more solid Christians, and most of
Okay.
them, their goal is to save sex for marriage. Like obviously, I have some people that have had sex prior to marriage, but the vast majority of girls that are listening, especially our younger girls, are not sexually active. Like they're really
Okay.
trying to wait until they get married to have sex, and I think that oftentimes like they're in their early 20s even and they're not sexually active, and I think a lot of them run into their doctor being like, sure, you're not sexually active. Like I think there's this, well, we assume you're a good looking person and you obviously could have sex, therefore you must be having sex. And so yeah, I often challenge girls to say like, no, like it's, and I feel like once you bring faith into it, then they're more likely to believe you. They're like, oh,
Mm,
okay. Cause I think they run into
yeah.
it with Mormons and then also
Yeah.
Catholics. And it's like, no, no,
Orthodox,
no.
Jewish. Yeah.
Yeah, exactly. Exactly. And so I think once you mention that, then they're more likely to believe you and be like, okay, so what would you recommend for, say, there is a girl listening, say she is 20, 21, she's
Hmm.
either not really dated or really only kissed. If she has dated, there's been no chance of STD. What would you recommend for her? Like, what should her plan be as she's preparing? Like, say she's like early 20s, she's getting engaged, she's going to be married in the next couple of years, but she hasn't been sexually active. What should her relationship with her gynecologist be?
Um, I, you know, I think she could go and meet the doctor and discuss whether or not a PEP is indicated. If there are no issues, no risks, she could probably hold off until she's actually sexually active. And I think they can come up with that agreement. Now, do you have to go 21, 22? Probably not. I mean, if she's doing well, periods are normal, no pain, no abnormal symptoms, etc. Does she even need to go to the GYN at that point? I don't necessarily think they have to. I mean, I think if they're mid 20s, try to meet them then, because once you start like, if you're getting married and going to be sexually active, that's the reason to get your pap smear. So
Okay.
she could even see her primary care doctor. Some patients will kind of transition from a pediatrician to someone like me, who's family medicine, then to an OB/GYN when necessary. So some patients should have a primary care doctor, and a lot of times they can guide them to, hey, when should I go to the OB/GYN? That makes sense. So,
Yeah.
I've had late 20s. I try to still do a PAP. I think that I worry about, I think later on, there's still like little inkling of risk, for like a 1% patient who, you just never know. And you don't want
Yeah.
to just not do it ever. And I talk to them like mid 20s, someone who is a virgin, like, okay, this is what we can do, use a teeny speculum, a lot of lubricant, that kind of thing.
Yeah.
So I always try to follow the guidelines with individuality, if that makes sense. So, but
Yeah.
yeah, so that's my recommendation for that patient.
Yeah. And then what if she does have pain? Like for me, as soon as I started getting my periods, they were extreme. I don't think I realized they were extreme, but I got very sick and like keeled over, curled up in a ball, having to have a heating pad on, very heavy periods, sporadic, not very like in sync the way they ought to be. And it wasn't actually until I dated someone whose mom did was a Creighton NAPRO technician. So they did cervical mucus. Like she helps women chart their cervical mucus. And then through looking at that, she's able to let them know where their cycles are and if they're at risk for things. Like she's told, I think she's had at least 5 girls that she noticed they had cervical cancer prior to their doctor noticing. And then others like me where it's been endometriosis. And she's like, I'm pretty sure the way your cervical mucus is, like you have endometriosis. Let's talk about these symptoms. Here's a doctor. So she got me to a doctor. But prior to that, I feel like I talked to doctors about it. I talked to my gynecologist about it. And it was like, okay, well, you're on the pill and you need to take more Midol or Tylenol or, and some people just don't have high pain tolerances, which really upset me because I feel like I do have a high pain tolerance.
I feel like that's gaslighting in a way.
Right?
And I feel like the things that I hear patients say, it's upsetting because I think, number one, even if you think that, you don't say that. And I think we have to understand that patients' experiences is important. And you don't know what their level of pain. If they say they're miserable and they're keeled over and they're passing out, that is not normal, first of all. And any kind of pain with your periods that affects your ability to go to school, go to work, be social. If you're avoiding events because of your period, I mean, granted, like sometimes you just don't feel good and you don't want to go. But if it's like, my pain is a 10 out of 10, I can't even function, I'm vomiting, I'm having all these other symptoms, that isn't normal. And even if you're on the pill, I would say your pill's not working and there's something else going on, or, I would try something else and do a further workup. I think that the longer you live with pain like that, the more a higher percentage you can develop other problems later on. So pain begets pain, meaning even painful periods can develop into other kinds of pain that can worsen your problem too. So that's something that I see as well. So definitely one is this endometriosis or not? I think it needs to be proven. 2 is pain that's affecting your quality of life is not normal, and then you can start having other things like sexual dysfunction and other things. So, definitely not normal. I would have, not I mean, so I try to, I think we have to teach pediatricians to doctors in general, listen to your patient, number 1, number 2, number 3. And if they're telling you something's wrong, there's something wrong and you need to investigate it. And you have to prove that there's, you know what I mean? Like that's to be proven, but to ignore it and to say, well, you just don't have a high pain tolerance. Or what I hear sometimes is doctors will say, well, that's normal. Everybody has pain, or parents will say that to their kids. And I'm like, that's not normal at all. And I feel like all it does is it makes them not want to talk about their problems and hide their problems even more.
Yeah. Yeah. And I feel like that's kind of where I went, was more hiding it or just like, okay, this is just how it is. And it kept getting worse. Right. So I eventually got to the point where I was exploding both ends. Like I would have a basket, vomiting and have diarrhea all at the same time on my period. And it's just like, well, this is it, like apparently I don't have a high pain tolerance. Like, and it's like, well, seriously, something's obviously wrong. And I had a laparoscopy and it got better after they did the surgery for the endometriosis. But I feel like that's something I'm always telling young women. I'm like, your body. Like if you are so sick, if something, and as you said, like if you, not wanting to go swimming, that's totally fine. Like if you're on your period and you're like, I couldn't be bothered getting in the pool and going swimming right now. I'm just going to lay out, whatever. That's totally fine. But when you can't function or you can't go to work, like, something's wrong and you need to. And when does it cross over? Like when are you, like I didn't even know chronic pain specialists. I didn't even know that was a thing. Like
Yeah.
even seeing someone at Cleveland Clinic when they referred me to you, like I didn't know that was a thing. And I was like, oh yeah,
Yeah.
no, I don't think I have pain, and like I have a lot of it,
You did. Yeah.
But
I
I'm
don't know
like,
what that is. Why are women, why are we supposed to just deal with things? I find that crazy actually. And I don't know, like we just put up with a lot of stuff and it's supposed to be, oh, normal. It's like, no, it doesn't have to be normal. Let's talk about it. Let's figure it out. And I think what happens is so when is a crossover? You said, some people think that kind of pain, painful periods for more than 3 months, 6 months, is still considered under the chronic pain category, even though you're not experiencing pain every day. But definitely when you have pain every day for more than 3 months, 6 months, 3 to 6 is sort of the gray area, but that's considered chronic pelvic pain. So, and it could be pain that's anything below the belly button to the hips, like upper thighs, is considered pelvic pain. So it can be lower abdomen, it can be your back, it could involve your hips, it can involve when you sit, when you stand, when you walk. So anything that affects like your activity, you can start having problems, like especially if there's pelvic floor dysfunction, which is one of the main things we see. The muscles in the pelvic floor tighten, and they tighten as a reactive response to pain. And it can be coming from cramping from the uterus, or it can be from an endometriosis nodule. So the muscles in the pelvic are like a hammock of muscles that just tighten because that's all they do. So that chronic tightening is what creates dysfunction down the road. And so it can spread just like, because all your muscles are connected and your pelvic girdle is connected to your legs and then your low back, you can start having pain all over, it seems like. So, and we'll talk about there's more to it than just that, because I think what happens too is they've actually shown through MRI that your brain matter changes too in dealing with chronic pain. So it isn't just like in your head, even though it is in your head because your brain's in your head, but your gray matter changes, and that's what can cause other problems down the road, in dealing with it. And then if you add on, depression, anxiety, stressful living situation, stressors from a job, anything else can also contribute to how someone's pain perception is and how they deal with it. So
yeah. And then stress adding on to that too. I was shocked this new pelvic floor physical therapist I'm seeing. She just like spent almost an hour like massaging my hamstrings. And I was like shocked by that. I was shocked at how I was like, oh my goodness, like, wow. Like I had no idea that like I was so tight because I felt like I always had to be curled up in a ball. And she was saying it's because of my hip flexors. That's what it is, not hamstrings, hip flexors. So she spent a long time massaging my hip flexors and then just realizing like, oh, wow, like it makes sense. Like our body is so amazing and so intricate, but like if we have one thing that's broken or not working correctly, like everything else does kind of overcompensate. What is something else that you see in a lot of your patients where like, do you meet people like me where you're like, I wish I saw you 30 years ago or 20 years ago?
Yeah, definitely. I mean, I see patients, a lot of sexual dysfunction. And I think this is the other category where I hate using the term gaslight because I feel like it's such a strong word, but I do feel like sometimes we're just told these things like, oh, sex is supposed to hurt. Yeah, I can feel like a little uncomfortable the first time. Pain, you should not have sex with pain. You shouldn't have sex with pain, period. Like it shouldn't feel sharp. It shouldn't feel burning. It shouldn't feel tightness is not really a pain that I would describe. But if you feel pain during and after, that's not normal. If you throw up after sex, that is not normal. You know what I mean? So I think that's another big category that we see. And often if someone has come to me and they're saying, it hurts to have sex, I ask them more questions. Is it a dryness sensation or what exactly is it? They say it's like a sharpness or a burning, you got to check them for other problems. So that's definitely another big problem. The other thing is because your pelvic floor controls how you pee, how you poop, and how you have sex, all those things can be affected by pelvic floor pain and even endometriosis. So urinary symptoms, frequency, urgency, leakage, bowel issues, diarrhea, all those things, even constipation. constipation can be a major symptom of pelvic floor dysfunction. Now, with endometriosis, sometimes you see the opposite, where if someone has nodules on their colon, or on their rectum or colon, they can start having diarrhea, usually associated with their periods. So you'll see a lot of things like that. Bloating is a pretty common symptom too.
Yeah. And what
Yeah.
is, so if someone's listening and they're like, oh my goodness, that's me. She's talking about me.
Yeah.
What do you recommend for them?
Well, definitely come and see either the OBGYN and ask them if the so when they go to the OBGYN, typically the exam's a little bit different and they can be screened. You can, if they're age appropriate, get a CD testing, get a pap, maybe do an ultrasound first. And if they're like, everything looks fine, I think you should go to chronic pelvic pain. So if they have all these symptoms and they're more than 3 to 6 months, go to chronic pelvic pain. We have in at the Cleveland Clinic, there's a referral, a consult to gyne pelvic pain that they place, and then we'll contact them. Our nurse calls and schedules them. In Ohio, it's more difficult to find someone who is probably not a surgeon. So I don't know, most of the time they're endometriosis surgeons treating chronic pelvic pain. If you're not at the Cleveland Clinic, if that makes sense. So,
Yeah.
yeah, you also will find some physical medicine or rehab docs that are, out in other cities or states that treat pelvic pain, but it's still not widely known. The knowledge is spreading, but it's still in some areas, not a lot of knowledge about or recognizing chronic pelvic pain.
Yeah. I feel like if I could go back to me early in my 20s or like mid 20s, like I did have a laparoscopy for endometriosis, so I knew that I had that. But I wish that I could have gone back and be like, you know what, just fly to Ohio. There's a doctor there; she can help. Because I feel like it would have affected all my pregnancies as well. And I had C sections, but I talked to a lot of girls that either like they're okay, that like the pelvic the pap smear is normal, the blood work's normal, there's no STDs. Like they're girls that have been with one person, their husband, and vice versa, and it's not, so it's like, okay, I have endometriosis, but I also have all this pain, and sex is painful certain times of the month. And yeah, and
Yeah.
I think that the natural thing for a woman, or at least this was me, but I think the natural thing is like, okay, we're gonna suck it up and we're gonna push through this and it'll get better. And
Yeah.
for this, it doesn't. That makes us worse.
No.
Am I right in that?
Yeah. I don't think it just gets better on its own. I think you have to recognize what the problems are. And, I think what we know now, again, I think the breadth of knowledge, especially in training surgeons, especially those treating endometriosis, they are taught now to recognize some of these other problems. Now, they might not know how exactly to treat it, but looking for pelvic floor dysfunction, looking for what is interstitial cystitis, for example. Those are other things that we
Okay,
haven't
so
discussed.
explain that
Recognize
to us.
IBS. So
Yeah.
interstitial cystitis is another chronic pain condition of the bladder specifically.
Okay.
And the thing is, it can mimic a lot of other diseases and vice versa. So the symptoms of IC are frequency and usually pain with urination. Your patients usually urinate a lot, like they could urinate all night, 4 or 5 times a day. And these are patients who may not have had children. So when I see someone who has a lot of painful urination and they haven't had a child, for example, it's really, they could have IC. And usually there's inflammation in the bladder wall, and it can be diagnosed through a cystoscopy. Usually a urologist who is a specialist in the bladder can diagnose. But that's a pain condition that we see sometimes that can kind of travel with other pain conditions. So,
Okay.
um,
Interesting.
so
And what are
recognizing
some
that
others?
other pain conditions, irritable.
Tell us more. Sorry, go
Yeah.
ahead. Go more into the endometriosis, because I have a lot of listeners that also have endometriosis. And then what are other things that are often connected with that maybe aren't diagnosed as often or as frequent?
Right. So I think endometriosis, so in general, endometriosis is an estrogen driven dependent disease. So what that means is usually you won't see usually the patients are much younger, and the symptoms can start when they start getting their period. So usually our average of a patient with endometriosis gets diagnosed in their 20s. This is different than other conditions. So first of all, two is there the endometriosis are nodules or implants that are found, and it's endometrial lining. So the lining inside the uterus is found outside of the uterus. So it grows and implants like almost like a tumor or a growth in the what we call the perineum or the lining of the abdominal cavity. It can also attach to the ovary and cause large cysts called endometriomas. It can affect fertility. It can also attach to tubes. It can attach to even the back of the uterus. It can attach to the colon and the bladder. So the more spread, the higher the stage. But what we don't know is why do some patients who have only a few nodules have very high levels of pain, and why do some who have a lot of it have little pain? So the stage doesn't always correlate with the level of pain for the patient. So that's another confusing thing that's still being worked through with research. So because it's estrogen driven, a lot of the treatments are aimed towards lowering estrogen levels. If you lower estrogen levels, you're going to have sometimes some side effects. For example, with the birth control pill, while you're getting estrogen and progesterone in the pill, it's driving your high levels of estrogen down a lot. So it's also obviously preventing pregnancy. You're not ovulating. Oftentimes we have our patients on continuous use hormones, so they don't use their placebo week. So that's the other thing is just you're doing continuous suppression. The other medications that are out there have a lot of side effects, but they can be necessary for someone who has pretty bad endometriosis pain. For example, elagolix and Lupron, which I'm sure some of your viewers have heard of. So there are different things you can use, the IUD, all these things. So we use a lot of hormonal suppression in addition to surgical consults. I think can be important for excision and treatment of these nodules. I would recommend going to a minimally invasive surgeon or MIGS, minimally invasive gyne surgeon. They've done an extra 2 years or 3 years of training in treating endometriosis. So I think that's important. I think that also you're seeing sort of a slow shift towards that. And I'm not sure I think that in the GYN community, GYN community, it's a little bit controversial. So, but if you're talking about the proper treatment and recognition of all these pain conditions and that endometriosis is not just surgical, you need someone who's done that extra training, I think, in order to treat someone effectively. But there are probably many surgeons who are not MIGS trained who do great surgeries. So you want to go to somebody who does it a lot if you're going to go to somebody who has a relatively high volume of doing diagnostic laparoscopies. So someone who does it a few times a year is probably not somebody I would recommend, and so go to somebody who's trained, who seems knowledgeable, who has good kind of reviews from other patients, who has a pretty good reputation with I would start with a general GYN or OBGYN. Who would you recommend? Usually they know who these surgeons are. So hopefully that helps start that conversation.
Yeah. And I've seen different doctors and the doctor and they've been different levels. And I don't think I realized that when I was like, oh no, I just need a laparoscopy surgery. So any doctor can do it. And it's like, oh no. There's actually endometriosis specialists that do multiple of these surgeries a day and they can get so much more, And is it common for after, so I had my second laparoscopy. So I had one before my husband and I ever met, before I was sexually active. I had one. And then I had another one shortly after we were married because I was at that point where everything was back, right? I was vomiting, diarrhea, like the works every time I had my period. And we wanted kids. We really wanted children. And I was told that I had stage 4 endometriosis at the age of 20. And it was, before I was sexually active. And so we got married. I got married at 23 or 24. I don't really remember. My husband's better at that stuff. But we wanted to have kids. And so I had another surgery, and then by God's grace, I was so thankful when I did get pregnant and that I was able to actually keep that baby. I didn't realize the risk of miscarriage being higher with endometriosis. So I was pleasantly surprised that I suffered through that pregnancy. Like I was so sick. I was
really?
hospitalized more than I wasn't because of the pain. I had so much pain. Like at one point they thought it was like I had stabbing pains. Like it was my appendix. They were getting ready to like, oh, we think we need to take your appendix out. And they're like, and your appendix is fine. You're just having all these crazy pains. And then, contractions too, like my whole third trimester. But my cervix like wouldn't dilate. It was just, and like you could see like hooking me up to an EKG machine, like you could see like they were really strong contractions, and they're like, oh yeah, like you're close. And they're like, and you're not dilated at all. And I was like, oh,
Oh no.
great. Thank you. I know.
You're like, this isn't fun.
I know. Quite disappointing. But yeah, we have a lot of girls asking about the endometriosis. So I think it's really good to point them in the right direction and getting someone that's really well trained.
Yeah, I think you got to start there. The other thing is, most people, well, I shouldn't say most, but I think you probably had something else going on, because most of the time, if it's just endometriosis, typically a lot of the symptoms will resolve actually when you're pregnant. Another thing girls are told is, well, just get pregnant. And they're told that it's kind of crazy. Like, I do think, yes, well, pregnancy can help, but I wouldn't tell someone who's not even dating, just go and get pregnant.
Not good advice.
Not a helpful advice.
No.
So
Find a really good father for your children first. And then if you would like children, get pregnant. Yeah.
It's just interesting what people are told, and I'm so glad people don't really say that anymore. But it's such like a paternalistic, kind of misogynistic thing to say. But yeah, most of the time patients feel a lot better, and I think in your case, maybe there was something else going on, muscle, and because if it so I don't know. Hopefully that a lot of that resolved, but.
Yeah, I feel like I talk to other people that are like that, and they feel great when they're pregnant, and I just wasn't. I was crazy sick like each pregnancy, which is just different. But I know, but that's okay. I love my kids, and I'm so glad that I have them. But I'm always telling people, I'm like, okay, like learn from my mistakes or learn from what I did wrong. But I have other friends that just have endometriosis, and they're like, I feel amazing. They love being pregnant. They say it's the best they've ever felt.
Yeah.
And I
usually
was
when
hoping,
they're breastfeeding, and breastfeeding also helps because your estrogen levels are even lower. So people who breastfeed, they like usually do fine, and then once they stop, they're like, oh my god, my pain's back.
Yeah, another bonus for breastfeeding. It's not just good for the baby; it's good for you as well.
Exactly.
Okay, I'm gonna go to switch over to some of our questions, if that's okay.
Okay, sure.
So our Patreon members wrote in to ask you questions. So someone is asking, how often do you have to go to the gynecologist if you're not married, not sexually active, and you're still a virgin? She's 35, and the last time she thinks it's been 10 years. She thinks she went when she was 25. So not in relationships with anyone. What do you think?
Yeah. So I'm assuming that means she had a PAP.
Mm-hmm.
Well,
she at least went to a gynecologist 10 years ago.
Okay.
I'm thinking she had a PAP. I don't know, though.
Okay. So I would say, so this is the patient, remember, where, I would still try to do a PAP on her because she's in her mid-30s. You just don't want to miss that 1%. And also, I guess, like, I would just approach and say, hey, how do you feel about doing this? This is what we can do. This is a speculum, sure, the little pediatric speculum. You can actually get away with using a little one, even though it's more difficult. You have to be used to using it. But it's actually not. Most patients, if she uses tampons too, I ask my patients that, because if they can use a tampon, they can have a pap smear. So I would try to get her in and try to do one at least to kind of more reassure both of us that we're not missing something.
So maybe even calling to different gynecologists, is this something that you could do? And then I'm sure if she gets a office that's super competent and they're like, oh yeah, not a problem, we could do that easily.
Do you have a pediatric speculum? And two is, I was going to mention some of the other health screening guidelines. And I think, again, mammogram, talking to her about starting to look at that. Are they doing a self-breast exam? Or getting that mammogram at age 40 is usually recommended. Has she had any other labs checked? Has she had her blood pressure checked? Checking her thyroid, doing an exam like a breast exam is still important. So there are lots of other body parts to check. she could even just go to an internist, do the rest of it, maybe not do the pelvic, and maybe reserve the pelvic for just the OBGYN, if that makes any sense. So I
Yeah.
still think their mid-30s, there's still things like checking cholesterol, checking for diabetes. I think those are other things that need to be at least checked for. Avoiding the doctor at all costs is probably not a good idea. They
Yeah.
should go in and kind of like assess the risk for other things. And colonoscopies actually, they're lowering the age that you start, like to mid 40s and 40 to 45. So it used to be 50. For some races, it's always been 40, but now because we're seeing colon cancer earlier, that's another discussion you start having in your 30s, just kind of
Yeah.
crazy. But yeah.
Yeah. And just being aware of, yeah, no, that's
Yeah.
really good. Okay. And then also someone's asking, when does menopause traditionally start and what are the symptoms? How
Yeah.
concerning should the cycle change be in early 40s?
Yeah. Good question. So I think, well, a lot of science, the average age in the US is 51. It hasn't changed that much really in the past 20 years, but about 51. But you can start having early menopausal symptoms in your early 40s. And the transition is the more important part. The transition is the hardest part. When you're done with your periods, at least you have stability because now you're done. And postmenopause is when you haven't had a period for a full year. So
Oh, wow. I didn't realize that.
yeah, that's when you're postmenopausal. But the menopause transition can start from your early 40s and go to as late in your late 50s sometimes. So but the menopause transition, there's usually 3 stages of it. And the first stage is usually not really recognized too much by patients, but usually they'll see some changes in their either the cycle length or their flow will change a little bit, but they still might get monthly periods. They might also start developing some symptoms around their period, such as hot flashes and things like that. When you get into the second stage, it's a little bit more obvious that there's changes going on. You can't always rely on the regularity of your cycles. And then the late stage is when your periods are skipping and like flows. In your cycles, actually, people assume you're going to miss your periods, but actually, what we see a lot is your cycles get closer together before they go farther apart. So if your cycles are coming
Okay.
like every 21 and they used to be 28 or 25 days, that means your periods you're starting to go through the change. But the change can be
Okay.
again like 10 years. So really you can still get pregnant even if you're going through menopause transition, even if your fertility risk is really low. Usually the percentage of getting pregnant in your 40 to 45 is pretty low, but it's still possible. So you still have
Yeah.
to worry. You still have to counsel women on like their pregnancy risk and things like that. So
Yeah, okay, and then that kind of goes into this next person's question. So women that have a lot of babies, that have large families,
mhm.
I feel like those are my friends that seem to be having more babies in their 40s, mid 40s, late 40s,
Yes.
and I don't know if it's because they're just that much fertile or because they've expanded their window of fertility by being pregnant a lot. And it kind of goes into this woman's question: what happens to the eggs during pregnancy? She's had 12
Yeah.
babies, and she's just wondering. She spent much of her fertile years pregnant, right? Or in postpartum, so she was
Breastfeeding or
breastfeeding babies,
breastfeeding.
right? Yeah,
Yeah.
yeah.
That is
Uh,
that's that's awesome. I'd like to talk to her. How does she do
I
it?
know,
But
right? 12 babies.
I
I love it.
I have 2 kids. I don't even know. But you can actually. So I had to look this up, but this is interesting. When you are born, you're born with. Wait, let me get my numbers out. You're born with like 6 million eggs, and um, okay, you're born with 6 million eggs as a fetus. When you're born, it goes down to 1 to 2 million eggs. So you're born with the eggs you're going to have the rest of your life, if that's crazy enough. Then when you go through puberty, it drops down to about 300,000 eggs. And then you start losing, before puberty, you start losing 10,000 eggs a month. After puberty, you lose about 1,000 eggs per month. And that is through pregnancy. So your pregnancy, you really don't ovulate. So obviously you only lose that one plus the 1,000 you're already going to lose. But if you're also breastfeeding, that also will you'll lose you also lose an additional egg per month then. But really, what we're seeing with menopause is a high percentage of patients, it is genetic and inherited. So really what your mom's, now it can be hard. If your mom had a hysterectomy, you won't
Then you just
know,
don't know.
but you don't know, but really, and it's an inherited trait. But also the number of kids you have, yes, can delay when you go through menopause, but it's probably going to only be about 1 or 2 years, to be honest. It's not going to be 10 years, but you can, I think people who are just fertile have it in their genes. And these patients that are getting pregnant in their late 40s, it is definitely probably genetic. And that's something, I hate to say it's not something they're doing, but there are a lot of factors with fertility. They age. I definitely think women are delaying, getting pregnant. That is definitely number one. And if you delay to 33, 35, your percentage is already dropping at about 35. So I try to talk to my patients about that. Unfortunately, we haven't been able to extend the fertility age that much with all the science out there. But two is smoking, alcohol, lifestyle, a high BMI, lack of exercise. I think stress, all of those factors.
Yeah.
And what about the use of plastics and like toxins in our environment? There's a lot of
Yeah.
things I think that we don't know that actually contribute to fertility. So
Yeah. My friends that have larger families, so like six or more, I have four, but I've had six pregnancy. But my
wow.
friends that have like probably six, I have a lot of friends that have between like 6 and 10 kids. I feel like 12 is a lot. I probably know
Wow.
someone, but I have to like rack my brain. But I know a lot that are like between
Oh
six
my
and
God.
10. But honestly, these women look amazing. Like they look way
Yeah.
younger than me. Like they're my age, but they look way younger than me. And they have like just this beautiful like skin that's like
Really?
it's not wrinkled. Yeah. And I'm like, why? I'm like, well, I see why
Why?
your husband keeps getting you pregnant because you're gorgeous. But like, I don't know. I don't know if it's the hormone change. I don't know what it is, or if they just have really good genes anyhow. But I feel like all my friends with a lot of children, I'm like, they look amazing.
Yeah. Yeah.
Like I
If
think you
if
would
people
think if
knew go ahead, sorry.
no, you go ahead.
That's awesome. I was gonna say if people knew that they probably would just be getting pregnant left and right. I
You're
don't
like,
know. I honestly don't know the answer to that. I would like to think it's, I don't know, genetic, hormonal, probably, because they have a lot of
yeah.
hormones that are, yeah.
Yeah, and then I think they're also more fit. Like I feel like they're not fit like they're going to the gym working out, but I feel like they're running around after kids. Like I remember people asking me like,
True.
"How'd you lose the baby weight?" I'm like, "Have you not met my children? They're wild and running everywhere." So like I have to run around after them. So it's maybe the woman that has like a phlegmatic baby that just sits and doesn't do anything, or a phlegmatic kid who'll sit and just color, that's like packing on the weight, because otherwise you got to run around after them.
That's very true, actually, because kids keep you young. I mean, if you have to like run after a toddler, plus you have to like cook all their meals and like do all the stuff for them, you are forced to move. You don't have an option. So that's
Right?
probably very true. Yeah,
Um
definitely.
Okay, that's great. Thank you. Okay, someone's asking about pain and cramping and nausea after intercourse. What
Yeah.
is that? I think she's probably shocked. She's like, pain, cramping, and nausea after intercourse. What is that? My OB has cast off as an impact of endometriosis, yet I found minimum in the literature. Yeah, like so sick after intercourse that yeah, you're nauseous or you're actually vomiting.
She's probably in so much pain she's throwing up is what I think, and I think she probably has to see me. No. No,
Yeah.
she may have pelvic floor pain. I mean, that's a huge, the thing is people like don't realize, I think, the impact the pelvic floor pain has on pain in general. So if you have period pain from your uterus, the cramping, you add on tight muscles, it actually can amplify your pain. And so when you have sex, typically, and I would ask her more questions like and check her for other things, but if you have uh, contraction of the muscles is called vaginismus, where the muscles sort of tighten at the entrance as a protective mechanism. That is something easily treatable with physical therapy. But the other thing is if you have deep pelvic floor pain with penetration, it can cause pain for minutes to hours to days after sex, and patients can be so bad that they throw up. So I don't know, like I would want to see that patient, see, are your periods being suppressed, are we controlling your period pain and checking for pelvic floor dysfunction as well as vulvar pain, vaginismus? So those are the things that we check for.
Yeah. And what if she has both of those? If she has both of those, what do you do for her?
You have to treat if she has an endometriosis that's still active, you'd want to kind of like talk about hormonal suppression. In addition, send her to a good pelvic floor physical therapist. Sometimes we use muscle relaxers. Sometimes, there's a lot of different treatment options for patients, not just physical therapy, but you can use other things for pelvic pain.
Yeah. And I think letting I'm not going to use your name because I don't want to use your name, but you're not alone. Like, you're not alone. Like, I suffer from some of this. I know other women that suffer from this. Like, I think it's something that it's like, oh gosh, like, this is shameful. We shouldn't talk about. No. This is like, if we broke our hand, like, we walk around with a cast on and we're not ashamed. We're like, we have a broken arm. We have a broken arm. I broke my arm. Yeah. Like, you're not bragging about it, but you're not ashamed of it. When someone's like, what'd you do? I broke my arm. But like, this is something that it's like hush, hush. And, we don't want to necessarily, you don't want to scream it from the rooftop and tell everyone, but it's something where I feel like, especially in circles of friends, we should be able to have this conversation. And I think that this is part of why I wanted to have you on, is like, this is something many women suffer from, and we need to have these conversations, and we need to talk about it and let you know that, like, you're not alone in this.
I think that, again, why are we supposed to put up with stuff? It drives me crazy. If a man said, well, every time I have erection, it hurts, he'd be immediately the doctor getting an ultrasound. He would be aggressively be like, oh my God, that's not normal. Like, something's definitely wrong. Yeah. So when a woman says it, why are we just shrugged off? This is normal. Live with it, deal with it, use a lubricant, drink a glass of wine. I've heard that too. It's like, it's such like a misogynistic viewpoint. And I think, it drives me crazy. It really does. Like, and I hope doctors and med students, they have to listen to what they're saying. And if you wouldn't want someone saying that to you, you certainly shouldn't be saying it to a patient. And all you're doing is perpetuating like the continued problems of pain. And like, it is traumatizing actually. And I think contributes to PTSD in some patients who are fearful of going to doctors, who've been ignored, blown off. It is like traumatic, So I just hope patients, like, you have to talk, patients have to be honest too. And they just have to say it. Like, even if they're not asked, to be like, you know what, this is something I heard is not normal. Is this normal? Who should I see? I don't like this. This isn't good for my sex life. Think about how many marriages it affects when your sex life isn't the way it should be. And something potentially could be treatable. And unfortunately, sometimes it isn't. It's hard to treat too. I mean, there are, sometimes it doesn't get better, but at least if you know what it is, you're like, I'm not crazy. Because that's the other thing is patients feel like I feel crazy. Like, I talk about this and no one's hearing me, so. Yeah.
And then also hearing like, okay, it's more than just pushing through something, it's not like, okay, you just need to be more relaxed. Because I think that is advice early on, like, especially if you're a virgin your wedding night. Like, I feel like someone gave me that as advice, like, just be as relaxed as possible, take a nice hot bath, have a glass or two of wine, like, drink a little more. I have a good friend of mine who called her mom her wedding night and it's like, Mom, this isn't working. Like, I don't know what to do. And she's like, put your husband on the phone. So she talks to her son-in-law and I love this. And she's like, listen. She's like, I want you. She's like, help her get relaxed. Draw a warm bath. Let her relax.
Right.
Give her a few drinks of alcohol so her body relaxes more. You don't drink any alcohol. You're fine. But let her get good and relax and then just be gentle and patient with her. And it worked. Yeah. Like, it was great. But I love that awesome. She felt so close to her mom to be like, Mom, we need to know what to do here, Right. And it's not like... Awesome. And I love that it was just like beautiful advice, like in this sacrament of marriage. It wasn't like, listen, get out a porn DVD, put it on, watch what they're doing, and then try to do that. And it's like, no, that's not what we want. Like, we're not trying to, it's not the issue of not being desired or whatever, getting aroused. Like, that's not it. Like, we are obviously attracted to each other, we're aroused, but there's more to it than that. So I think that there should be something where it's like, and I think maybe that's part of it too with the pain, where it's like, I have another question here about really low libidos and low desire for sex. And I think this is a question, especially Christians, I think, are a little more hesitant. Like, we're not going to Google it. I'm not going to Google this, but like, I'll talk to my friends about it, but I don't want like, I don't know. I don't want erotic stuff that's not beautiful. Like, that's
Right.
not what I want. That's not what I desire. I don't desire to watch this group orgy and be like, oh, now I can orgasm like that person. You know what I mean? So I think it's something that we want to be like, I think there's a right reason to want to be protective of this. And you're like, I want it to be a good, beautiful thing between me and my spouse.
Yeah.
But I don't know who to ask.
Yeah. Well, I think so libido is drive. I think that drive can vary, libido can vary. Just like when you're talking about cervical mucus, well, the reason cervical mucus changes is because our hormones are changing, and the ovulatory discharge indicates that you're fertile, and usually drive accelerates when you're fertile. So I think that if women are so the thing is, lots of things affect libido though too. Like I always say, women's brains are the biggest sex organ that we have. Men, we know what theirs is. So if you're stressed, tired, kind of like depressed, whatever, if you have a lot going on in your brain, you're worried about work or family, your sex drive is going to be usually affected, whereas men, it probably won't. And I don't want to generalize, but I think that is in general true. So
I think that sounds
you're
true to
right.
me too. Yeah,
I
that
think
sounds
it's
right.
true. And so I think the whole thing where men need to work a little harder, that's probably true too. I mean, your woman needs to be relaxed. Like maybe you do the dishes and like take care of the house, and you'll probably notice an improvement in sex drive. I don't want to sound sexist, but I think that when women have too much going on, they can't really be in the moment. And I think that's really important when you're trying to have sex and enjoy it. There was and also medications, like if women are on antidepressants, those are a big libido killer.
Oh, right.
And other things like even the birth control pill, which is, I use a lot of pills, but we have to understand that they do lower testosterone and estrogen, and so they are going to affect libido. Now, for some women, they don't get affected. So we see that unfortunately with some of the medications we're actually using to treat their other problems. So that is kind of a difficult thing that I see. The other thing is, there was a good question about orgasm, I believe. There was somebody who, and I think this was like a good segue into that. It was somebody she couldn't have orgasm through pain, through just sex, right? Her sensation,
Okay.
like she felt like she wasn't enjoying it. So that patient, if she doesn't have pain, I think he's not focusing on the right body part, which is the clitoris.
Yeah.
So this is where I would pull out a photo anatomy, and I would say, is your partner touching this spot? Because most women orgasm through clitoral stimulation, not vaginal penetration, which is why I was going to bring in
Right.
porn into this, because porn, I think, makes women feel very insecure about our bodies. Well, a lot of those women have had surgery. They've had like labiaplasty and like have no hair down there. It's like so unrealistic that I think porn has created this huge problem in what men think sex is supposed to be and what women think sex is supposed to be. So we should just stay away from porn. I think it's horrible.
Yeah.
There's probably more healthy porn out there, but I'm just saying
No, but
that,
I'm a firm
you know,
believer in staying away from all porn. All porn.
right.
My husband actually, that's what he does. Well, he runs a YouTube channel and stuff too, but he also
Oh,
talks about. He's written actually, I should bring you his book. He's written a non-religious response to the problem of pornography, and he interviews a
yeah,
lot of neurologists, and it's great. But he's basically talking about how horrible it is, and it's ruining
it is.
people. It's ruining our
It is.
society. Yeah.
It's
No,
ruining and teens too. Like teens watch porn, and what
I
they
know.
think it's supposed to be is like that is it is
That's
not at
not.
all what it's supposed to
Yeah.
be. So, I mean, I do
And
think that's a problem.
yeah, I
Yeah.
liked what you said too about being less stressed. At some point, I forget when, I think we had one or two babies, and my husband would get home from work and say, Cameron, why don't you go relax, have a hot bath? And this kind of became like our nightly routine. Like we'd have
Aw.
dinner together, and then he's like, honey, you go relax. Like I put down the baby, or I put down one kid, and then he'd have the other. He's like, me and this kid will clean the kitchen, and you take a nice bath. He'd light me candles, and I was like, this is great. I'm like so
Aw.
relaxed, and but it was just like kind of perfect, and it made it so much easier. And then we had like a romantic evening, and it was like, oh, this is nice. My kitchen's cleaned. I feel loved and supported, especially in
Right.
those days that I was breastfeeding and I just had toddlers at my ankles that like just they needed so much of me. So to go from that to be like, hey, honey, and I'm like, don't touch me. People have been touching me all day. Like, I love you. I realize
Right.
that you also have needs. I realize it's different, but I'm in like mom mode and I can't switch to wife mode that quickly. And that really helped.
So
Like
true.
once he started doing that and realizing like, okay, and it's like, honey, I know you're probably stressed. Would you like a massage? And it's like, I would love a massage, and just letting, I don't know, challenging our husband. So if maybe your husband's giving you a hard time, it's like, you're never in the mood. Be like, well, you know what? You could maybe clean the kitchen while I take a nice hot bath and then you could give me a massage and then we'll be together and renew our wedding vows, have the marital embrace. And I think like if you let him know, like, this is what I need, like, this is what's arousal to me, like it's so much more, it's making sure your whole heart and your whole person is being loved. And then I also think, yes, obviously anatomy as well, knowing that the clitoris is what stimulates so much more.
Right.
You're like, okay. Yeah. Being aware.
She mentioned something about a low cervix. I don't actually think that has anything to do with that problem. So so I think hopefully that'll work if she can pull out like an anatomy phone and be like, okay, or show him this is where I want to be touched. Maybe she doesn't know. I don't know. So sometimes you just have to sort of, if you feel like in a trusting relationship, you can just sort of experiment and be like, this is what I like. This is the pressure, blah, blah, blah. Use lubricants as much as you need to, but also, like you said, be relaxed. Maybe they need a lot more foreplay and not just get right into it, So
right. Yeah. And telling him like, be gentle and here we go and communicating. And I feel like it's part of like, that's part of the beauty of marriage. Like this is supposedly your best friend. So you may try something that doesn't work, but you'll both laugh about it and we'll never tell anyone about this or whatever. But you just kind of have this fun inside joke. I was looking for that question. I'll keep looking. I don't see it, but that sounds wonderful.
It was at the top. I don't know where it was, but I think that was the question. And I was going to mention other medications. Antidepressants are a big one. Except Wellbutrin or bupropion doesn't affect libido. So we often will use that in addition to someone on like an SSRI, which is like Prozac or Zoloft, those kinds of medications. Allergy meds sometimes I think are drying because they dry up, mucus and they can dry up cervical mucus. And the birth control pill, like I said, is a big one. So the IUDs don't tend to affect dryness and libido as much. So sometimes we have to switch patients off a birth control pill and then put them on use an IUD intrauterine device.
Okay. All right. Here we go. This may be the question. I'm not sure. I'm going to go ahead and read it and we'll see. We'll just kind of go in this direction. Newly married, 4 months and counting, and by grace, I remained a virgin until marriage. But frankly, I feel like I was lied to about sex. It isn't painful, but it isn't enjoyable. It's neutral for me. Though he always climaxes, when does this change? What can I do? I enjoy the foreplay, but as soon as we actually have intercourse, it does nothing for me, no matter how aroused, relaxed, or lubricated I may be. I never orgasm or come anywhere close to it. Not for our lack of trying. I've read that some people just can't orgasm, and I'm wondering if I'm one of them. Though no doctor has ever indicated that to me, that anything's anatomically wrong. I do believe I may have a low cervix, or maybe it's just psychological. I don't know, but any input would be helpful.
Well, I think what I want to know too is, can she orgasm by herself? Because if she can't, might go further. Also asking about her history, blah, 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 all those things. So if really she's not on any meds, and she's enjoying foreplay, but she's never had an orgasm, it's like I would probably try to have her orgasm by herself first and see, and is she stimulating the right part? You know what I mean? So she may be assuming that you don't need to stimulate the clitoris if you're having vaginal penetration, that you should be able to orgasm off of that. And I'm wondering, he may have to do both. You know what I mean?
Right. Yeah. He may need to do both. Yeah. So we don't, as practicing Catholics, we don't really do self masturbation. So I feel like
Okay.
I see your suggestion, but she's gonna be like, no.
No.
So like
Okay.
we could be together with our spouse, and come together. So I think that maybe it is him and her trying, trying to figure out how she gets best aroused and focusing on that prior to him getting aroused. I also have friends
Yeah.
that once he like once he already climaxes, that she, like, I have a friend that says she can always climax after him, like she will orgasm after her husband, but she's not able to before.
Okay.
So that is, I think what she's saying with that, my understanding of that is it's probably clitoral stimulation at
Yeah.
that point, because he's relaxed and they're still, together. And so that's my guess,
Yeah.
is it's more clitoral after the fact. Someone commented on this and said, I had a very similar suggestion at the beginning of our marriage. Keep persevering and communicating. Focus on relaxing down there. Food grade oils are safe as lube and are way less sticky. Coconut oil is a good suggestion. We made a lot of progress on our own as we continue to communicate and persevere. I worked on trust and letting go of control. It's a beautiful gift to your husband to persevere, continue to hope, and I think that's good, to keep hoping.
Yeah.
Like, just because you have an orgasm doesn't mean you won't.
True.
Yeah.
It's
So
good we can't. It's good we can get pregnant without that, because can you imagine, like, pregnancy rates would be a lot lower, I think. So
yeah.
it is. I think it's. I do think the oils and things that helps, and I do think the clitoris. People don't realize how many nerve endings that are in the clitoris. It is the female equivalent of the penis. So it's definitely, it's so sensitive. That's why there's a little covering over a hood. So um I don't know if it's just so small. Like, I don't know. I still think she needs to, like, focus on that and talk to her partner and focus a little bit more as they're doing it. I bet you that that's what the problem is. Seems to me.
Yeah. Yeah, no,
Yeah.
that sounds right. What is she mentioned, I don't know if you know this, the percentage of people that actually don't climax?
Oh gosh, I have no idea. Off. It's not
It's not
as
high
high.
though,
I
I
think
don't
it's
think.
it's not high just off vaginal penetration. Maybe, like, I don't know, 20 or 30%. I don't think it's as high as other. So
Right.
vagina does not have a lot of nerve endings. It's not like, it's just like the extension of your, it's different tissue, but it doesn't have a lot of nerve endings. It's more the
Yeah.
entry and the clitoris and the labia, actually.
Yeah. Yeah, I
Yeah.
think you saying the clitoris is the equivalent of the penis makes sense. And it's like, oh yeah, because they're so sensitive, right?
Yeah.
And then being like,
Yeah.
oh yeah, because it's not all of us. It's, yeah. Yeah, no, that
And
makes sense. That's,
embryologically, it is the equivalent. So
oh,
embryologically, it is the equivalent. Yeah. So,
I didn't know
so there
that.
you go. That's why
There you
it's so
go.
important.
Learn something new every day. I'm like, okay, that's good to know.
Yeah. Right.
Um, yeah, no, I think it's yeah, I think it's interesting, and it's hard to, like, this is where, like, I'm angry at the porn industry for so many reasons and so many people that are addicted to it and everything else, but I think they've also distorted something that's really good and beautiful, and made us feel like unless we're emulating that, and it's messed up. Even people that aren't religious are like, no, this has messed them up. Like, there's,
Oh, it's
with,
totally messed up.
yeah, with erectile
It's
dysfunction, it's like I could take a picture of my girlfriend in front of me and look at it and be aroused, but looking at her can't be aroused. It's like, that's so messed up.
it's crazy. Well, it's a whole, like, social media too creates, you have, it sort of like dehumanizes, I think, women and men. I just don't think it's just not, doesn't show people in a healthy, sort of loving relationship. And if there was more emphasis, I don't think it would sell as much. Like, unfortunately, I think it's so graphic, and it's like, kind of, we've become so desensitized to, like, even violence
Hmm.
and graphic images. Like, they just needed to make it more and more and more and more, and it becomes this, like, crazy thing. You're like, what are these people?
Yeah.
So, and it's so accessible. It's just really, it is very disappointing, and I think it's created problems in how our young people, you know, um, sort of, like, think about sex, actually.
Yeah.
It's
Yeah,
too
agreed. I think it's
casual,
done. Yeah, way, way, way too casual. Agreed.
Yeah.
Um,
Yeah.
okay, our next question is what is the relationship between migraines, thyroid, and ovarian ovulation cycles?
Ooh. Um, the thyroid in itself can affect ovulation. If your cycles are changing, and it's one of the first things we check. If something's changing your cycle, I check the TSH as a simple kind of test. But other than that, thyroid doesn't typically affect fertility. With migraines, it's interesting. You can either see migraines with periods, which improve on the pill, or you can see migraines that get worse on the pill. So sometimes you have to ask those questions like, what are your triggers? And, there are definitely some migraines can be triggered by hormonal changes. That's all. So I think you have to ask those questions and get a bigger pattern on what their migraine patterns are and when they occur. Many things trigger migraines, though. So it's not such a simple answer. And I think to say the pill worsens all migraines, that's not necessarily true. Some of the types of migraines that we see, we actually treat them with birth control pill, like we'll do continuous use and suppress hormones, or even adding estrogen. Sometimes it's from period migraines or from estrogen dropping. Sometimes if you add estrogen supplements, you can actually improve migraines in that way. I think it's important to kind of get a bigger history, making sure you don't have something called aura, which can be equivalent to a higher risk of stroke with the birth control pill. So anyway, I mean, there's a lot of questions I think that have to be asked and before you start treating someone with or without hormones. So
Yeah, and then
I'm sure
is
I answered that
migraines
correctly.
awful? I know, I feel like it's really hard, but
It's
and
hard.
then someone else was asking something with no, you did a good job answering. You're great. With migraines with menopause as well. Is that more common to suffer from migraines towards and is it also more of a hormonal thing?
Actually, sometimes we see migraines improve. It's a lot of times migraines are hormonally driven. So once you get past the postmenopause and once your hormone levels drop, usually because you're not having any ups or downs with your hormones, migraines actually can improve. So that's something that we see quite a bit.
Okay, and then on that, I love the way she just puts this. She's like, I talked to a lot of women about 40-ish who are struggling with hormone gynecological issues from as simple as sleeplessness and anxiety to complete systems gone haywire. My doctor says it's normal for this season, late 30s through menopause, but they never warned us about this crap in health class. Can you talk a bit about this and what's actually normal, what to expect, and what helps tame the hormones, and just a bit of a field guide to all of this? Thanks in advance.
So that's another, just like with pregnancy, the experience of perimenopause is going to vary person to person, and menopause varies person to person. So there is a lot of fluctuation. They don't treat, they don't teach us in health class because in health they're kind of more worried about getting preventing unwanted pregnancy and talking about your normal menstrual cycle. So normal menstrual cycles, you get nice up and down, sort of even, and they're like all at the same level with the hormone levels up and down, nice cyclic pattern. But when you start going through perimenopause, you have sometimes too much estrogen, not enough progesterone, and the hormones are kind of like up here and then down here, and then like they're not all evenly spaced. And that's what creates I think a lot of the symptoms related to perimenopause, which can be moodiness and breast pain and bleeding issues are probably the number one thing we see. Libido change, weight change. It's really annoying and aggravating. And so, what is I would recommend actually the North American Menopause Society. I am a North American Menopause Society certified practitioner, which means that I have extra training and I've done the certification test for perimenopause and menopause education. And so everybody's different. I think that while we like to blame everything on perimenopause, it's not always the cause of everything, but if you're seeing cyclic changes and you're seeing a pattern related to your hormone, your menstrual cycle, it probably is related to your hormones, is what I would tell people. Like, for example, moodiness right before is definitely a hormonal condition that we see. Perimenopause, it can worsen. You can actually get more angry and more agitated pre-menstrually, and that can be related to the changes in your hormones. So it isn't something made up. I just think we have to take care of ourselves. Basically, we have to get enough sleep. At this point, usually your job, if you have a job, it's usually more demanding. You're probably working more hours. You're at a career where you're sort of maturing, and then you also have kids. You probably have teenagers. You have all these other things that are happening and now your body's kind of going through haywire. So I think being on a regular sleep schedule is super helpful. I think
And how many hours would you say that should be?
I think that varies, but I think in general,
Okay.
Americans don't get enough sleep. And I think 7 is probably like a good average. If you get 4, you probably need more like 6 or 6 or 7. I usually like to get 8, and
I feel like I need 8. If I
I
don't get
need
8,
8.
I
I
feel
need
like
8
I'm more
minimum.
likely to get sick, or I'm more likely, to be
I have a
irritable,
mess.
and yeah.
Yeah, you're not. Then you have to. Then you feel hungrier because you're tired. Then you want to eat more. So it all drives this process. So I think stress management is important. I think taking care of exercise, whether it's walking or getting out and doing things you like to do, you want to have what they call balance, but I think it's a perceived balance, where you have time with your partner and your kids, but work, you shouldn't be overtaking. If one thing is overtaking your life, it's usually probably not a good thing. So,
Hmm.
but I think all that can help smooth that transition. I don't, some people, we put them on hormonal pills. I don't tend to treat with hormonal therapy unless someone's postmenopausal or in that late menopause transition. So,
Okay, yeah. I
yeah.
yeah, it's funny because I laughed at the health class thing because it's like there's so many things that I feel like we weren't taught. It's like, where are we supposed to
No.
get taught this? Like, but it makes sense, for you're not gonna tell teenagers everything for every. Although I think it would be more helpful. I think it would be helpful. I plan on teaching my girls. My girls haven't hit puberty. Well, my girls haven't had their period yet. I have one that's like starting to enter that puberty stage, but just talking
Yeah.
to her about her body and emotions and
Yeah.
I just think it's good. Even when we were young, when they were really young, my daughter's like, "Mom, as if I have way more eggs than you." And I'm like, yeah, that's true. This is like my 4-year-old telling me she has way more eggs than me. And I'm
Oh my
like,
God.
that's true.
She
Who
does.
who told you that? And she's like,
How'd you
Dad
know
told
that?
me. Because her
Oh
womb's
my
so
God, that's funny.
special and sacred. Yeah, she has a womb. She's like, my belly's
Oh my
better than
gosh.
Dad's because he doesn't have a womb, but I have more eggs than you. And I'm like, yes, these things are true. But I think like talking to it with children
That's
is
funny.
also really good. And what do you think?
Yeah.
I want to talk to like the mom out there who's like, how can I better educate my child? So they either have teenagers or they're like me and they have like 9, 10, 11, 12-year olds that are like right on the cusp of becoming teenagers and changing. Like in an ideal world, how would you want to love these young children that are beautiful, sweet, and innocent and haven't been ruined by these things, and exposed to stuff they shouldn't be exposed to? But those girls in particular, how would you explain to them what's going to happen to their body and like set them up for a very successful, healthy female health?
Yeah. I think that we have to be realistic. And I think using the real body part names, I think is important. Vagina, vulva. I mean, if you teach, I think going really, really deep in anatomy probably is not necessary, but kind of saying, okay, this is what your uterus does, this is what your ovaries do, this is what your vagina does, and this is, I don't know. So talking about using parts, there are books I used. I don't remember the names of them, but there was one for a boy, one for a girl, and we used that. And I think starting with books that are made for their age level, I think is important. Reading through it and making sure it's honest and realistic too. But I think that even if you tell them all that, that's good, and that they're in charge of their body. I think
Mm-hmm.
boundaries, what's appropriate, what's not appropriate, and I think there's so many things that we have to start discussing with our kids at 9 and 10, even like if they have phones and things. So there's so much out there, social media, blah, blah, blah. If you think your kids doesn't have Instagram, they probably do. And they start at 11 or 12, and so you have to monitor that as well.
Especially if they have phones or they have like unlimited access on a computer. There's a woman, Kristen Ginseng, I believe is her name. She has a book called Good Pictures, Bad Pictures, Porn Proofing Today's Kids. And that's a really good one, especially if, and she has them geared towards different ages. But it's talking, so I really recommend her book. But I think using the right anatomy is huge too. I remember someone telling us early on, they're like, if your child, even just little things like is sexual abuse, like if there is, not that you want sexual abuse to be involved, but they're like, there's often code names and nobody uses like the right name. So it's like, we had a friend that was like, I don't know if it was a policeman or a detective, but he said that they would say, oh, this is your, I don't know, flower or whatever, or like, this is our special time, just you and me, and touch it, like whatever it is. God. But it's all like code names, and they're like, if your kids have the language to be like, no, you may not touch my vagina, it like shuts down that person. It's like, okay. And they're less likely to, I mean, not that you can, completely keep your child safe from abuse, but they're less likely to abuse a child that knows anatomically correct names. That's and like, true. No, you cannot touch me on my penis. That's not appropriate or whatever, like having those things. And then also having really good doctors. Like I remember my doctor asked I think it was my daughter, like they were doing an exam and she was very young, and it's like, okay, now mom's in the room and I want to talk to you. Like I would like to examine your private area if that's okay. And she's like, do you mean my pagina? And she's like, do I mean pagina, mom? I'm like, she means vagina, yes. And that's okay. And she's like, normally the answer's no, but mom, is it okay for the doctor? And it was so good and so innocent and beautiful. Get permission. Exactly. And it's like, okay, I just want to see, like she had a bruise, and she's like, okay, so what's great is it's here on your hip and your thigh. And I just want to make sure. And, and just having that like safe conversations and good doctors and like, this is how it was handled in this environment. And then and then I also think like, with periods, I feel like it was something that like just wasn't my generation. I feel like we didn't talk about it. It was like, hey, I put a box of, tampons under your sink when and if you need them, and pads. And like, that was it. Or like, what was it? It was Girl Scouts. I remember being at Girl Scouts. That was the talk. Or Girl Scouts, like saying like, here's a tampon. This is what it looks like. You insert it, and it's like, okay, well, I'm glad there's Girl Scouts. Otherwise I wouldn't know, like I'm sure I would have eventually figured it out, but how do you recommend talking to young girls, and especially as they're getting ready to start their period, about their body and using correct language, but what else can we do?
Yeah, I think having them buying pads and having it all prepped, having a bag somewhere, and they can talk to the nurse about, usually the nurses have stock, so you can go to the nurse if it happens at school. Okay, this is what's going to happen. This is why it's happening. This is what it means when you don't get your period. And I just think preparing them, like you can start with a pad, and if you want to use a tampon, I can show you. Just being open and honest about it, I think, is a helpful thing. But I don't know. I don't think you have to. I think just having that open dialogue, like you can come to me. I won't ask you any questions. Just come and I'll help you. That's all you have to do. And I think then your daughter will probably come to you, and won't be embarrassed. Yeah. If you don't talk about, if you don't feel weird, if they sense you're weird about it or embarrassed, they may not want to talk to you. I don't know.
I feel like that was me. I didn't tell my mom for the longest time that I started. And then I overheard her like telling someone else, Cameron still hasn't started to appear. And I'm like, oh gosh, I guess I should tell her I have. But I didn't want to just like tell her.
She's like, oh, that's funny. That is
because she called, my sister is 14 months older than me, but she called all of our family members and was like, Meredith's finally a woman. And I was like, oh my goodness, that's mortifying.
Oh my God.
Like, I
She
don't want
did
that.
not.
She did. She did. So I didn't want her to do
So
that.
funny.
And then a few months after, I don't even think I was on my period. I had a test that it was like a pop test or pop quiz, and I hadn't studied for it. And I was like, I know how to get out of this. I tied my sweatshirt around my waist and was like, Mom, I need you to come get me. She's like, I'm not going to get you. And I'm like, Mom, I think maybe I started, And she's like, I'm on my way. She brought me home,
way.
like bought me some pads, and I was like, score. I got out of my tests, and now she knows, and I don't have to have an awkward conversation.
Win-win.
Yeah, but I don't want that for my kids.
No.
I want to have
You
an
want them
open
to tell you.
dialogue. Yeah. My daughter's friend was at our house, and she wasn't feeling good, and she was just kind of curled up in a ball, and my daughter was very concerned for her, and she's like, she doesn't feel good. And I talked to her, and I was like, sweetie, I'm like, I'm so sorry. Would you like some tea, or could I get you a heating pad? And she's like, wait, do you know why I don't feel good? And I was like, yeah, I think I do. And sometimes watching a movie or putting a heating pad on my stomach helps. I also have pads. Do you need a pad? She's like, how, Mrs. Frad, how did you know this? Like, she was just shocked. And I was like, well, sweetie,
God.
I don't know if you know this, but I'm a woman too, and I also go through that. And my daughter's just like
that's
looking
nice.
at me. I don't know if my daughter knew what was going on as well. Like, she did know, but I don't know if she knew the words and stuff. And I'm like, you know, one day, like, you'll have your period, but I want to help you if you ever need to talk about it. And it was a beautiful experience, and she felt loved, and I made them popcorn, and they watched a movie and had a heating pad, and it was just like I don't know, something beautiful, and not something that I don't know, I think sometimes we think it's something shameful, or like, don't
gross or
acknowledge it.
something. Yeah.
Like, it's gross, or don't acknowledge it, suck it up and just be normal like everyone else, because that's what we expect of you.
Right. Well, I think there's a lot of I love what girls are doing, and I think that this whole thing about having friends, I think that's something not really at schools. It might be a little bit more available, but yeah, I mean, I think the whole thing surrounding periods is just interesting, and there's just a lot more education out there, and I think that's wonderful. I think our girls are going to be growing up in a different age where they're going to talk about stuff more. I think boys, we may need to catch them up on stuff. I don't know, but girls, it seems like they're okay. Like, my daughter, I was like, okay, whatever you need, we're gonna do this. She's a dancer. Well, she started using tampons without my knowledge. Like, and I was kind of annoyed because I thought, I wish you would just come to me. And she's like, well, my friends showed me or whatever. She said, no, she said she read the pamphlet. She just used the pamphlet and just looked at the picture. And I was like, well, I was a little bummed. I was like, I really
You're
would've
also
liked to-
you're a doctor. You're trained in this.
Yeah. I was like, I would have liked to have taught you, but that's fine. I was proud of her for being independent, but I was just kind of like, oh, she didn't need me. She's growing up without me. So, I mean, that's a good thing too. Don't get me wrong. But I think that, the more we can do to empower girls, being prepared, I think you have to start age 9, probably 4th or 5th. Yeah. So,
I feel like my 9-year-old grasps more and understands more than my 12-year-old, which is funny because she's obviously going to get her period before my 9-year-old. But like, we try to do like all the organic beef and non-hormone milks and all of that to kind of prolong, because I think I started kind of young, so I'm thankful that she has not. And with my family history of endometriosis, I just want to do everything I can to help keep her, I try to buy like, I don't use dryer sheets, and try to buy I used to buy organic underwear. I haven't been doing that the last couple of years, but just things that I thought of. Whenever I thought of it, I'm like, oh, that should be good. I should do that. Or I think they make better pads now, where I feel like, and tampons. I feel like when we were kids, it's all chemicals and we're like, oh, look, we put these perfumes in it so it doesn't smell. Great. What is that perfume actually doing to the inside of it? Actually, could you talk to that? Is it harming
I think the
me?
whole
I'm
thing,
assuming it's bad for me.
Yes, I would never don't use anything that has scent. And I think this whole thing where a vagina needs to smell a certain way, really, that's another thing that's pet peeve of mine. These commercials.
And who's putting their nose in my vagina?
Well, they're probably all, I don't even know, but I think hopefully just one person. But no, but this whole thing where we need to smell a certain way is really, I think people need to recognize what's not normal. Like if there's a fishy smell or if it
Right,
smells
right.
like a death, that's not normal. But really, there is a scent to our normal bodies, and we shouldn't try to hide that up. And I think that creates problems like skin allergies, like doing too many dryer sheets, fabric softeners. I don't use scented pads. I don't use scented anything. I don't think they make a lot of scented tampons actually, but the scented pads definitely I stay away from
They
that.
did
And
when we were kids, though. Do you remember them
I don't
when we
think
were
they.
kids?
Yeah, kind of. I don't know. I'd have to look to see actually, but I
Okay.
think like to
Or maybe it was the
don't douche.
applicator that was scented. I don't know. I remember
I don't
something being
know.
scented because
I
that's what
always
we
stayed
had.
away.
Yeah,
Yeah.
not a good
I mean,
idea, but
not a good idea. Like, don't douche. Douching's a problem. Don't douche. Why do we need feminine washes? Why do we need, like, I think the
yeah,
whole
I
Bath
don't
and
do
Body
that. Why?
Works. Don't do it. Just use white Dove soap. You don't in water and just rinse correctly, and you'll be fine. You don't need to don't use feminine sprays. This it's not good for you. Like, it's just all not good. So
Just
because
shower
it
or
can
take a bath, right?
shower really actually a bidet is good because a bidet it like rinses everything and that's fine. You don't need a feminine wash. The problem is like it does can leave a chemical and create skin allergies. And look at the chemicals, what's in something, and look at how many skin allergies we have. And the vulva is a very sensitive spot because it's like moist and warm and like you can have
hmm
itching and then that's a whole other problem. So it's not common. I don't see a ton of skin allergies, but I will see irritation from chronic pad use and liners and things. So white cotton underwear, I say thongs are okay, but they can create like some skin irritation, and they say it's more commonly associated with yeast infections, which might be true.
Oh,
So and definitely like not sitting in moist, sweaty clothing is a good idea. So, but I think avoiding anything scented. If you have to cover a smell, then you probably need to deal with the smell if it seems
right.
abnormal, not just cover it
Yeah.
up. Yeah.
Yeah, no, that does. It's like, okay, no, if something's smelling, it's like you should go in and be like, okay, I don't know why this
Check
is
it
going
out.
on. I remember
Yeah.
like at one point I had some like GI thing and I'm like, it smells like gross rotten eggs when I burp. And it's like, that's gross. And I didn't want to tell anyone, but the people around me could tell. And I went to a doctor and it's like, okay, yeah, actually that's a sign of this. When it's we call that a sulfuric burp. And it's like,
Oh
okay,
my
this was
gosh.
good. This was helpful. And I think it's the same.
Yeah.
It's we should be dealing with it even more so because it's a very uh, intimate area, to have those
Yeah.
conversations and yeah, and yeah. Yeah, no, I think that's really good. And I think that there are more, like I found some like organic, all natural pads, and that's what's currently in my house
Yeah.
for when we need them. And I think that's good. And I think especially people, like I had really heavy periods. So what would you say to a girl if they just have
Mm,
really heavy periods and they're like, I need a tampon
yeah.
on and a
Yeah.
pad, and it's just a lot? What's
I
your
would.
advice to her?
There's also what you can do. You can double underwear. You don't have to. There are those underwear that are like $30, $20 a thinks. I think it's called. Those have just like another. They have like some sort of special material that absorbs all the
Absorbs.
moisture within the yeah. But I've heard those are good. But they're expensive, and I think wearing an extra large pad and using an extra large tampon is fine. I just think if you're soaking through those every hour, that probably is not normal, and I would probably get that
Right.
checked out. Yeah.
Okay. Yeah. Yeah. Well, thank you so much. I really appreciate you coming on and just
Thanks.
having this chat. And I feel like even if someone's like, okay, well, if Dr. Strasberg and Cameron could talk for over an hour on this, on so many different
Oh
topics,
my
like,
gosh.
like my hope is that it'll just give them the confidence to go have the chat with their doctor.
Yeah,
Like, I feel like we
definitely.
talked about a lot of very intimate things and you were just so wonderful and beautiful. And thank you
Oh,
for
thank
taking our
you. Thanks,
questions.
Cameron.
And yeah, I really appreciate it. You're just so knowledgeable. And, yeah, I honestly wish I met you years ago. So yeah, thank you
Oh,
for letting me share you
thanks.
with all of my listeners because it's just going to bless so many women. So thank you very
Thank
much.
you. Nice to talk to you.